So let's continue talking about clearance of medications and how that process occurs. If you need to close the doors, feel free. All right, so we mentioned that both clearance and the volume of distribution is going to help us determine what the half-life of a drug is. And what is half-life? All right, it's not just a very good video game, it's also how long it takes for you to get basically 50% of the concentration in the blood of that particular drug, right? So some drugs will have half-lives measured in seconds, some of them will have half-lives measured in days to weeks, okay? It just depends on the drug that you're dealing with, it depends on lots of different factors, right? And so the patient can be affecting this as well. I mentioned pharmacokinetics is what the body is doing to the drug, and so if you're changing some of these factors in patients, if you're altering their volume of distribution, or if you're altering their ability to clear that drug, it's going to have a direct effect on half-life. Okay, this is why some patients will be dosed less frequently with the drug because they have poor kidney function and they can't clear the drug very well. And the drug sticks around for longer, has a longer half-life. So basically, clearance is going to be determining the amount of drug that we're eliminating per unit of time, usually like per hour or whatever happens to be, but usually hours is going to be the most common one. And then the volume of distribution tells us how much volume actually needs to be cleared. So we mentioned that the kidneys are primarily involved with clearance of drug, and so if you think about it, like you were thinking about bloodstream and the central circulation, if you have a drug with a small volume of distribution, where is it mostly at? In the tissues or in the central circulation? Yeah, mostly going to be in the bloodstream, right? So, and again, if I were to measure that blood level, it would be very high because most of it's going to be stuck there right in the blood. That means that most of the blood's going to be hitting the kidneys pretty quickly, right? Makes sense. That's where the kidneys get this blood flow from, is the central circulation. If I have drug that is really far distributed out into the tissues, a drug that has a high volume distribution, it takes longer for that drug to partition back into the bloodstream to be cleared by the kidneys. So typically you'll find that things that have like a small volume of distribution that are in the bloodstream have an easier time being cleared by the kidneys because it's right there in the blood already, right? Versus having to wait for it to distribute out of the tissues, get into the bloodstream, and then get cleared out. So we'll see how volume distribution and clearance are going to have very important factors on how we dose drugs and how often we're going to be giving drugs. I'll give you some examples of that as we go forward. And clearance is also going to help us to determine what a steady state plasma level of that drug is going to be. So does anyone can think what steady state would mean? No net movement in or out. That's close. Essentially, it's a constant level of drug in the bloodstream. Absolutely. So basically, the amount of drug that I'm putting in is equal to the amount of drug that I'm taking out per unit of time, okay? And so we'll look at some examples of how we can achieve steady state concept. And I'll illustrate why that is as we go forward. But there's two main ways that drugs can be cleared from the body. We're going to talk about first order elimination and then zero order or capacity limited elimination. You'll find that most drugs follow first order elimination. Basically what this means is that we're eliminating a constant percentage of drug per unit of time, and it's going to be proportional to the concentration. So the higher my concentration is within the blood, the more drug that I'm clearing, right? So I have a very small amount of drug in the body, I'm going to clear it pretty slowly, right? Because it's going to be the same percentage of drug per unit of time. So, if a half-life is, say, we'll show you some graphs of how that actually works in just a second, but basically, if the drug is, 50% of it is cleared every hour, that means that, if I started off with, say, 100 milligrams within the blood, in an hour it'd have 50 milligrams, and in another hour it'd have 25 milligrams, and so it's all proportional to the level you actually have in the body. On the flip side of that is zero order kinetics, and basically this is going to be a constant amount of drug eliminated per unit of time. So 20 milligrams per deciliter per hour. That's as fast as I'm going to be able to eliminate this drug, no faster, no slower. And a lot of it's going to be related back to the ability to metabolize it, usually based on enzymes, right? So if I overwhelm those enzymes very easily, then I'm going to be at a point where they can only work so fast, and so only a certain amount of drug can be metabolized per unit of time. A good example of this is ethanol. I'm sure some of you guys have had some experiences with this, but this is why you can say, like, well, someone should metabolize a drink per so many hours, right? Because it undergoes a zero order kinetics, where I can say that, okay, if a patient comes in, they have a level, do you guys know what the legally drunk level is? 0.08 or 80 milligrams per deciliter, essentially. So if a patient comes in and they have a level of 100, and they are relatively, they don't have any other concomitant disease states or anything, I can say that, well, they're probably metabolizing roughly 20 milligrams per deciliter per hour, which is kind of an average. And I can say, well, I know that if I check that guy's blood level in another hour, it'd be 80. If I check it in another hour, it'd be 60. It doesn't matter how high his level starts out with, I'm only going to be able to metabolize 20 milligrams per deciliter per hour. Okay, you'll find that that will change depending on several factors. So chronic alcoholics, they have an upregulation of liver enzymes, and so they can actually metabolize much more quickly. People who are naive or alcohol naive are probably going to be closer to that level. Okay, so again, a lot of it's kind of based on averages. We'll use that in the ER specifically because we can say, like, well, we got a level on this guy. He's drunk as a skunk right now. When can I estimate that he will be sober and I can discharge him? So say, well, if he started off at a level of 160, which is twice legally drunk, I can say, well, probably in, say 8 hours, he should be down to nothing at that point, right? So he should be completely stone sober. Usually they just wait till they're less than 80 before they send them off. But that can be a useful way to actually use your knowledge of kinetics to say when this patient should be ready to go home, right? So if you were to look at the elimination on a graph, you would see with zero order kinetics, again, this is going to be capacity limited. The same amount of drug gets metabolized per unit of time. So every hour, the same amount of drug is going to be metabolized. Doesn't matter how high I start or how low it gets, always the same amount. On the other hand, when you have first order kinetics, again, it's going to be proportional to your concentration. So you're going to see that when you have very high levels, the metabolism, large amount of it's going to be metabolized very quickly at first, but it's always going to be the same proportion of drug per unit of time. So whether it be 50%, 30%, whatever happens to be, it's always going to be that same percentage regardless. And I'll show you some more graphs here in a little bit that will make that a little bit clearer. So looking at our first order elimination, again, most drugs undergo first order elimination, so it's a good thing to remember. Basically, we can look at the concentration of the drug and also the rate of the drug administration, and that can kind of tell us what the clearance is going to be. So kind of a handy equation that we'll use sometimes is that clearance equals the amount of drug that we're putting in, right? So this is our input into the system, and it's going to be divided by this drug concentration. And so essentially what I can also do is taking this variable here, this rate of administration, I can change it out for the dose that I'm giving divided by the interval. And when I say the interval, what do you think that means? This is how frequently I'm giving a drug, right? So some drugs are given Q24 hours, right? Some drugs are given Q12 hours. Some are given Q8 hours. It just depends. But basically I can look at the dose and by the interval, so usually divided by how many ever hours I'm giving it, and then divided by that drug concentration. And so if you're looking at this, you can see that if I put a bigger dose in to the system, what does that do to my clearance? Well, if I put a bigger dose in, my clearance should go up, right? So again, because this is all going to be proportional to the concentration, it's always going to be the same percentage of drug metabolized per unit of time. So if I give a bigger dose, I get more clearance. Okay, if I have a smaller dose, I'm going to get less clearance. It's always going to be the same proportional amount. Okay. So knowing this, looking at this proportional relationship between drug concentration and the proportion of drug cleared per unit of time, it's always going to be proportional here. I'll show you some examples in graphs in a second. So for instance, if I was looking at a drug, let's say I put in 1,000 milligrams of a drug into the body, and I'm looking at my time at time 0. So say I give them an IV push dose of a drug, 1,000 milligrams in the system right now. Say for instance that the fraction of drug that gets eliminated per hour is 15%. So notice here, it's always going to be the same fraction, always going to be 15% of the drug that gets metabolized per hour. So during that first hour, I have 150 milligrams eliminated, right? If I were to go another hour, notice here that it's still 15%, but now it's 127. Now it's 109. Now it's 92. So the amount of drug I'm metabolizing per hour is going down, even though it's the same proportion, right? So keep that in mind. So you can see this graph here, looking at the half-life of the drug over a unit of time. So you see half-lives being expressed here. Usually this will be expressed within hours, so you can look at the kinetics of a drug and see, like, okay, the half-life is usually this many hours, for a healthy patient. You see the concentration again, basically going to be going down the kind of this slope, where if a higher concentration, more drug gets metabolized. So we normally don't look at curves like that necessarily. Usually what we end up using is the log of the concentration, and that will actually turn that first order elimination curve from kind of a sloped line over to a straight line. And so this can be really, really useful for us. And we use this very frequently when we're actually doing what we call therapeutic drug monitoring, or measuring blood levels of a drug in order to determine how fast a patient is clearing it, what their volume distribution is, to determine what their optimal dose and interval of the drug should be administered. And so basically we have this elimination constant. This is really important for telling us how well that patient's clearing that drug, and it represents the fraction of drug that gets eliminated per unit of time. I'm not going to have you actually calculate natural logs and stuff in your head on the test, but the concepts are what's important to look at here. Okay, so basically what we can do is we can plot out a patient's drug levels over time. So for instance, a very common one that we do is a drug called gentamicin. Gentamicin is a really good antibiotic against gram-negative bacteria. So if you have like patients who are have like a bloodstream infection with like say E. coli or Proteus or something like that, we can end up giving gentamicin in order to help eliminate that. So essentially what we can do is we can measure serial levels of the drug in the patient's system, and by plotting this line out, we can get, usually all we need is 2 points, we can get a line out of that, and that'll tell us how quickly the patient's eliminating that. And so we can look at the natural log between the peak and the trough. Okay, so those are another concepts we'll be talking about when we get to therapeutic drug monitoring. Generally, when you're measuring patients' levels, you're doing it at a peak time, right? So that would be right after the drug has been administered, or a trough, and that would be right before the next dose is administered. That would be the lowest level the patient achieves before the next dose is given, right? Basically, you're comparing this natural log of the peak and trough over the change in time that occurred. So I can get 2 points, as long as I'm taking into account how far apart those points were taking, I can get this elimination constant. The other thing you can look at here is that the KE, elimination constant, is going to be proportional to the clearance divided by the volume of distribution. Okay, so if I clear the drug more quickly, for whatever reason, that causes my KE to go up, right? On the flip side, if I change my volume of distribution, say I increase my volume of distribution, what does that do to my KE? So the denominator is bigger now. KE should go down, right? So, and this is important because you can have patients who can have altered volumes of distribution for drugs based on do they have burns, do they have ascites, right? So do you guys know what ascites is? What is that? It's just kind of full of fluid, right? All drug can go into that fluid too, and if you have a very hydrophilic medication. So that can be one thing. If they have CHF and they have a lot of venous distension and they're having a lot of drug hiding out there, the venous system, that can all affect their volume of distribution. And we have to take that into account and how that's going to affect the clearance of the drug, okay? So again, just note that more clearance is going to equal a bigger KE, and a larger volume of distribution is going to lead to a smaller KE, right? Bigger volume of distribution, again, more of that drug is out in the tissues, harder for it to get to its site of elimination in the bloodstream. Okay, so I mentioned half-life is going to be the time it takes for a drug's concentration to drop by 50%. So pretty straightforward. So for instance, if I had a drug A that was at a concentration of 20 micrograms per ml at 4 p.m., and then I got a concentration of 10 micrograms per ml at 8 p.m., what would be the half-life? 4 hours, right? So then if I measured a level, say at midnight, what would the level be? Should be 5, right? So again, it's always going to be proportional. So the half-life is always 50%. If I know the half-life of a drug is so many hours, I can estimate what the level is going to be at a given time, right? If I know what that kind of first point is. For instance, if I was looking at drug B, had a concentration of 40 micrograms per ml at 8 a.m., and then I had a concentration of 10 micrograms per ml at 4 p.m., what would be the half-life there? So what's the difference in time? 8 hours, okay. And then how many half-lives have occurred? 2. So 8 hours divided by 2 is, right, so still it has a 4-hour half-life, right? So drug B and drug A both have the same half-life in this situation. You have to take into account when the levels were taken, and also be able to plot that out with the actual drug levels themselves, and you can figure that out. Again, you guys typically will not, I mean, we do this when we're dosing things like gentamicin, we're doing that therapeutic drug monitoring. We will actually figure out, because you'll have kind of population kinetics, right? When you're looking up a drug reference and you see gentamicin has a half-life of so many hours, that's basically population average, right? But we know that our patients are all a little different. They're all a little bit of snowflakes. And so you can actually, doing drug levels, you can figure out specifically this patient's KE is this patient's half-life is specifically this, and dosing the drug based on that. 99% of drugs, you don't have to do that in a lot of cases. The dosing's already been kind of done for you. But for those drugs that have a narrow therapeutic index, you guys remember what that is? It's a narrow therapeutic index. Yeah, so it's easy to go from therapeutic to toxic just with small changes in dose, right? So for these drugs where you can see there's a narrow therapeutic index, it's important that we're doing levels like this so we can make sure that the patient's getting the right dose to, say, kill off their infection without giving them kidney failure, right? So it's usually the kind of line that we're going to be kind of walking to make sure patients are getting the most benefit without getting toxicity.
Since it went down in concentration by 30, wouldn't it be a little different in 4 hours? I was just confused on the math.
No, so if you think about it, so for instance, we saw that, so if the drug started at 40 micrograms per ml and it underwent 1 half-life, what would the level be? 20, right? So if it underwent 1 more half-life, what would it be? See? Yeah. So again, we're not doing the same amount of drug per time frame. We're doing the same proportion of drug per time frame, right? So again, if I were to take this out for another half-life, you're metabolizing even less drug because there's just less of it floating around the bloodstream to interact with those enzymes or interact with the kidney or whatever it happens to be. Okay. Yep. Again, I mentioned learning pharmacology is like learning a second language, and so this is all part of the dictionary that we're picking up our terms and our concepts in. Again, so just looking at the half-life, you can see that again, 50%, another 50%, another 50%. We're progressively getting smaller and smaller amount of drugs being metabolized because there's less of it around to interact with metabolizing enzymes or being cleared through whatever organ it gets cleared through. Okay, so we mentioned half-lives can be extremely variable from drug to drug. Adenosine, you guys know what we use adenosine for? Yeah, so supraventricular tachycardia. So if you ever have someone who has like a heartbeat of like going like 180 or something like that, we can give adenosine to try to reset the heart. Essentially, it's really interesting. Has anyone ever seen adenosine being given in person before? It is one of the scariest drugs you can actually administer. Basically, you hook up the patient to a continuous EKG to where you're monitoring their heart rhythm. Again, they're going super fast, say 180 beats per minute, very fast for them. Patient's kind of feeling faint. You give adenosine, and basically what it does, it just shuts down the heart. So basically, they end up having super fast. They could flatline for like a second. Everyone in the room's like, oh gosh, and then hopefully they come right back in a normal rhythm, right? That's the goal. No, I've never seen anyone actually say flatline for that long, but that's because the drug has a very short half-life, less than 10 seconds, and the drug has been eliminated. 50% of it has already been eliminated, right? This is also really important when we're administering adenosine, because if I give, say, I have a line in the antecubital vein, giving the drug, it takes a little bit of time for it to get back into the heart, right, where the actual mechanism, where the actual site of action is going to be. If I give that just kind of real leisurely, if I'm just kind of pushing it, that 10 seconds has already gone up, and I have a lot less drug hitting the heart, right? So this is one of the situations where you have to have a setup where you're pushing the drug in super fast, and you have a saline flush behind it pushing that fluid through, so that way the venous return is going to be a little bit quicker, gets to the heart, and fixes the rhythm. Okay. So again, knowing the half-life of these drugs is important in some cases because that can change how you administer the drug. So on the other hand, you can have a drug like amiodarone. This is a very common ventricular, or a drug used for ventricular arrhythmias. It's used in ACLS when you guys hit advanced cardiac life support. Has a half-life of 26 to 107 days. So that means it takes a long, long time to clear that drug because it for whatever reason, does not interact with enzymes in a very fast manner, but it sticks around for a good long time. And this can also mean that for patients who are taking this on a long period of time, we'll look at steady states and how those work. They can have drugs sitting around here for a very long time after they stop taking the medication. They can still be affecting them. Okay, so knowing how long a drug will last in the system can affect different things like, are they going to have withdrawal effects? Are they going to have continued toxicity even if I stop giving the drug today? They may still have drug levels sitting around for weeks afterwards. Okay, so these are things that I'll consider. Yes, ma'am.
When I used to work, we used to do like adenosine and glitter stress test.
Okay.
So, I mean, that would just like so I guess it can be used for that, but it can also just be used to like increase the heart rate or something?
Not necessarily increase the heart rate, because when you give adenosine is kind of like it's similar to GABA in a way. We mentioned GABA as being like a major kind of inhibitory neurotransmitter. You give adenosine, basically kind of stops everything, right? So it's like a major break on the system. It can cause seizures, or if you have an adenosine antagonist, you can actually see seizures from the CNS perspective. I'm not familiar with using it for stress tests, so I'd have to actually research it to see, but they're probably using smaller doses than what you would see for SVT in order to try to stress out the heart a little bit, to try to make it not work as well, to try to induce that stress to see okay, are they having ischemia occurring, what's happening here. So I have to look it up to know more about it, but yep. All right. So how do we calculate the half-life? I will not have you actually divide anything by the KE, but these are important concepts to take. There will be some calculation on the test. It'll be very easy for the most part, but I'll show you what those are going to be when we get to them. So anywho, if we know what the KE of a drug is, and again, most of the time we'll know that based off of population kinetics, right? So we've given the drug to lots and lots of people through clinical trials and things like that. We know kind of what the average is for most people. Basically, you can figure out what the half-life is by using this number 0.693. There's a reason why that number exists, but I'm not going to make you guys know that. But you divide it by this elimination constant, and then you can figure out what the half-life would be for that person. Alternatively, we can substitute in we know that KE is also equal to clearance divided by volume of distribution. And so the more useful information we can sub in here is that the half-life is going to be equal to 0.693 times the volume of distribution divided by clearance. Okay, so what does this mean for our half-life when we change some of these factors like volume of distribution or clearance? So for instance, if I increase volume of distribution, what does that do to my half-life? Makes it longer, right? So the drug's going to stick around for longer, especially if it's partitioned out into the tissue, right? Versus something like clearance. If I were to decrease the amount of clearance that I have, what does that do? It would increase the half-life, yeah. So if clearance is going down, so if I have poor kidney function or something like that, you will see that the half-life is actually going to go down. If I were to increase clearance, what does that do to my half-life? Should make the drug get metabolized more quickly or cleared more quickly, should cause half-life to go down, okay? And so this is important when we're looking at individual patients. We can see like, well, they have severe burns and they're causing, you know, massive fluid loss and it's altering their volume of distribution in this way. That they're going to be processing that drug a little differently than someone else who did not have severe burns or someone who had massive edema or something like that. And similarly, looking at things like kidney function. You know, if a patient has poor kidney function and the drug is really reliant on the kidneys to eliminate it, that's going to lead them to have a longer half-life. Drug sticks around for longer. You'll see that the levels will actually rise in the system, and that can lead to toxicity. So these are very, very important concepts to understand, that changing volume distribution has an effect on half-life. Changing clearance has an effect on half-life as well. You have a question?
So the symbol for half-life is T1 half?
Mm-hmm.
Okay. I just didn't know if that was like T was a different constant than 1 half.
Nope, no, T1 half is going to be, that's all. I probably should have subscripted that, but yeah, that's how you will see it being referenced. Okay, so for instance, we kind of talked about this already, but if half-life is equal to 0.693 times the volume of distribution divided by clearance, the larger volume of distribution is going to do what to half-life? Should increase it. If I have a smaller clearance, what should I do to the half-life? Should increase it as well. If I'm not clearing the drug as quickly out of the system, it sticks around for longer, right? That, you know, makes pretty good intuitive sense. So keep these relationships in mind. Okay, this is a super important concept for therapeutic drug monitoring, which you guys may not be doing directly, but it's important to look at a patient and say, like, for instance, you know, a big thing that happens I see a lot is that, especially like ED providers, right? ED providers, usually they just want to give a single dose of something and get them either discharged or get them disposed up to the floors or ICU or wherever they're going to go, right? So oftentimes they don't take into account a lot of these kind of relationships, because I can give a single dose of a drug and not really worry about the internist or the ICU doc. They'll figure out the rest of that stuff. But if you have a patient who's coming in and you know that, okay, they have poor kidney function, I can go ahead and kind of proactively alter the dose or alter how frequently I'm going to give that dose in order to make sure that they're not going to get toxic, or to make sure they actually get a big enough amount to actually be therapeutic, right? So it's important to keep these in mind. Notice, you know, these drugs you're using, you'll kind of have an idea like, okay, they have poor liver function, I need to alter this drug. Or they have poor kidney function, I have to alter this drug in order to make sure I'm getting my levels in the right amounts. Okay, so the next concept is going to be steady state. This is going to be where the rate of drug elimination is going to be equal to the amount of drug I put into the system. Okay, and you're going to find that this is going to be the clearance is going to be proportionally constant, and that's going to make the average steady state level going to be equal to the amount of drug I'm putting in. So if I have a larger clearance, I would have to put more drug into the system in order to achieve the same steady state. If I have a smaller amount of clearance, I need to put less drug into the system in order to achieve the same steady state. Okay, I'll show you some graphs and show you how we can achieve that. But essentially what you can see is that the average concentration that we'll get when a patient is at steady state, we'll use this variable CSS, the concentration at steady state, is going to be equal to the dose that I'm giving divided by the clearance times the dosing interval. Okay, so again, some drugs are given every 8 hours, some every 12, some every 24. That'll have a direct impact on what the steady state level is going to be. So if I'm looking at this, if I increase my dose, what does that do to my steady state level? Should make it go up, right? So again, I'm putting more drug into the system. It's going to cause the level to go up in that case. If I were to have my clearance decrease, what does that do to my CSS? Also going to increase as well, right? Because I'm not clearing it as well. The drug is going to be sticking around the system for longer. And then if I were to say increase my dosing interval, say I was giving a drug every 6 hours, and then I decided to give it every 12 hours. What do you think that would do to the dosing interval? Or do to the CSS? That would actually lower it, right? So we're going to look at some different dosing strategies and see how that affects our steady state levels. But dosing intervals are going to be really important in this as well. And so where we use this very frequently, especially over at Nemours, is when we have premature neonates coming in. We get a lot of transfers in of some very sick neonates coming into our hospital. And so when you're looking at how to dose drugs, you have to look at what their gestational age was, right? So what's gestational age? how long the baby got to cook before they got popped out, right? So for some of these kids that are very immature, they're premature when they came out, say like, you don't see too many 24-weekers, but like, normal gestational age is usually like 38 weeks or so, 37 to like 42-ish. Some of these kids will come in, 26 weeks, 28 weeks, and they're very immature, and they don't really have, their kidney function is not very good, their liver function is not super good. We have to extend out how frequently we give these drugs to make sure they get the same steady state levels as a kid who was born at 38 weeks. Okay, so that means that we would have to give them, say, a drug that we'd normally give every 12 hours, maybe we give it every 36, or give it every 48 hours. We have to extend out that interval because we know that their clearance is so low that we have to give them a bigger dosing interval to make sure they get the same level, right? So note here that if you were to have decreased clearance, but you increase your dosing interval proportionally, you get the same steady state. That make sense? Okay. So, kind of already talked about this. So dose should have a directly proportional relationship to CSS, where if you have more dose, more drug going into the system, a higher steady state level. We mentioned that increasing the interval should decrease that level. Yes, ma'am. You could also give a lower dose. I'll look at why that could be a problem, though, because in some cases you want to achieve a certain level in order to be therapeutic, right? So I'll show you some graphs in a second to make this more clear, but essentially you need to give enough drug to actually hit a certain level, but then how quickly they metabolize it can affect how frequently I'm going to actually administer the drug. Yeah, very good question, though. Because again, if I give too small a dose, yeah, they clear it pretty quickly, but I would never get therapeutic, right, to kill off bacteria or do whatever I need to do. So a really important number to remember here, and I'll probably ask this like 9 million times throughout the rest of pharmacology, the time it takes to get to steady state is roughly 4 to 5 half-lives. Okay? So if I have a drug that's a very short half-life, 4 to 5 half-lives, I can get to steady state pretty quickly. Drugs like amiodarone that has half-life in measured in weeks, that can take a very long time to get to steady state. And there's going to be a way we can get around that, but just realize that it takes 4 to 5 half-lives to get to steady state level. Okay, so essentially this is probably, the contrast isn't super good on here, but anyway, so again, steady state is going to be where the input rate is going to be equal to the elimination rate. So for instance, if I were to give a continuous infusion of a drug, so I hooked up an IV to you and I would give you a continuous infusion of a drug at, say, 10 milligrams per hour, right? What you'd see if you were to plot the concentration is you see this concentration start to increase, 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 and you'd hit this equilibrium where the amount of drug I'm sticking into the patient is equal to the amount of drug being eliminated through the liver or the kidneys or wherever it happens to be, okay? If I were to keep that dose steady, they would continue to eliminate at that same rate, and I would achieve the steady state, presumably forever, right? And if I were to stop that infusion all of a sudden, then you see the level drop off, normally undergoing that first order kinetics in most cases. Okay. So if I were to give a larger infusion, if I were to give more drug during that time frame, you see the CSS go up, right? For instance, if their kidney function took a hit and it caused them to not clear the drug so well, that would also cause the CSS to go up. We may not want that. It may lead them to have toxicity in those cases. Okay. So, but how frequently do you think we're giving continuous infusions of drugs? You think very commonly or not very common at all? Not super common. Like, how do we normally give drugs in majority of cases? What route? Orally, right? Yeah, so we're not going to, it's kind of cumbersome to hook up a patient to an IV and administer them drugs, continuously. It's kind of a big impact on their life, right? But they can take a pill, no problem. So you're going to see that the dosing interval and how frequently you're administering the drug can also lead to what we call an average steady state. So for instance, if I were to give you a drug via continuous infusion, you can see here this blue line how the level is kind of just steadily going to go up, and then you'll hit that plateau effect, right? So that's, again, where the drug entering into the system is equal to the drug leaving the system, okay? I can get the same average steady state by administering the drug not as a continuous infusion, but say as an intermittent administration. So for instance, if I were to give you IV boluses, right? So I'll give you intermittent doses, not continuously, but just every hour or so. What you'll find is you'll have the kind of an increase in level immediately after I administer the dose. You'll start to see some metabolism occur, some clearance of the drug occur, and I give another dose. It'll pop back up. You start to see drop down a little bit. If I pop it back up by another dose. And eventually you're going to find that you'll hit this average steady state where even though you may measure the level, say right after a dose, and it seems high, it's actually not. It's going to be the average that we're concerned about at steady state. That make sense? I'll show you another example how we can kind of compare and contrast different intervals and how that's going to have an effect on what our steady state is. Okay. So looking at this graph, you can see here again plasma concentration on the y-axis here, time on the x-axis. If I were to give this drug via continuous infusion, Notice 4 to 5 half-lives later, you're going to end up at this steady state level. Okay, so that's kind of our average steady state if I were to give it via continuous infusion. So what I could also do in order to achieve that average steady state is I can give intermittent doses. So you're going to give a big bolus dose here, level's going to drop a little bit as metabolism occurs. I give another dose, another dose, another dose, another dose, and eventually you get my steady state, right? And you notice kind of this fluctuation between how high the level gets and how low the level gets is going to be proportionate to the amount of time between doses and how big of a dose I'm giving there. Because I can achieve the same steady state concentration by giving a much bigger dose, but giving it less frequently, right? So I can give a big dose, get a big high level here, have it drop down pretty far, give another dose, give another dose, and notice here that it still takes about the same time to get to steady state. I've had to give fewer doses to get to steady state in this case, but in the time frame is always going to be the same. But notice here I'm getting much higher peaks, much lower troughs than if I were to give the drug more frequently, but the steady state level stays the same. Yes, ma'am.
So what's the benefit of giving one versus the other?
So glad you asked that. I have a very good reason for that. So like we were talking about, with some drugs, you want to maintain them in a certain level, right? You want to make sure that the peaks don't get too high to cause toxicity. You want to make sure the troughs don't get too low to be subtherapeutic. So a really good example of this is with antibiotics. Okay, when we get to antibiotics, we'll talk about things that are concentration-dependent killers, to where I want to get a really high concentration to blast out the bacteria, kill them all off, and then we have what we call a post-antibiotic effect, where even if the levels drop down to zilch, the bacteria are still dying off, right? They've acquired some of that drug, they're getting killed off. Some of them are going to be called time-dependent killers, where you actually want to maintain a certain level, a certain average steady state for a long period of time, because if the drug levels drop too low, the bacteria can start to repopulate again, right? But if I keep the level high enough over a prolonged period of time, I can continue getting that bacteria being killed off, okay? So for instance, you guys familiar with the drug penicillin? All right, so penicillin is a pretty good, pretty narrow spectrum kind of antibiotic, but I use it occasionally for several different types of infections. But that's what we call a time-dependent killer, where you want to make sure that you get above the level to where you are killing off the bacteria. So usually they'll have some kind of minimum level you have to get over in order to actually kill the bacteria. But I want to make sure I don't get my levels too high, because that may lead to toxicity. You see some problems with the patient, right? Versus something like Levaquin. Have you guys heard of that drug? That's a different class of antibiotics we use for probably way too frequently for lots of different infections. But Levaquin is going to be a concentration-dependent killer, where I give that one, say, every day. I can give a big dose. And if it drops very low, I don't really care, because I'm still getting the bacterial kill. You know, something like penicillin, I have to give, say, every 8 hours, every 6 hours to make sure I stay within that kind of narrow range. But some other drugs, it doesn't matter how high I get or how low I get, as long as I'm achieving that same steady state level. Does that make sense? Yes, ma'am.
Sorry.
Yeah.
What was the name, the definition of that, like, threshold of therapeutic versus toxic?
So that would be essentially the therapeutic index, right? So because again, I'm looking at my ED 50 versus my my toxic dose 50, and so essentially when you're looking at the way that a drug is dosed or the way that it's how frequently it's given, they've taken that all into account, right? These studies have already been done for a lot of drugs. So when you see penicillin, you give 500 milligrams every 8 hours. That's in order to, in most patients, on average, you should be getting levels right in that kind of that window to where you're killing off the bacteria without seeing toxicity. For most patients, everyone's a little different. Versus if I see a drug like Levaquin, I'm giving every 24 hours. They've already taken this into account. Okay, so most of it's already kind of done on the backside, but we do this very frequently. There's another antibiotic that's really good for gram-positive infections called vancomycin. You guys ever heard of that drug? It's a heavy-duty gram-positive killer. That's a drug where you actually don't want the troughs to get too low, so we have to make sure that we're maintaining this kind of very narrow kind of spectrum here, where the troughs don't get too low to where the bacteria can continue growing. We also don't want to get our peaks too high, because you see ototoxicity. You can actually see the hair cells get damaged, and they can lead to hearing loss. You can see kidney dysfunction that can occur. So it's really important to make sure we're maintaining ourselves within that therapeutic window. Makes sense for everyone. I'll give you more examples of this as we go forward.
So that one you just tell them to take more often and it's a lower dose, basically.
Essentially, right? So we can do that, but for instance, that's a drug we're really only going to give in the on the inpatient side usually. So we would say, okay, well, based on your kidney function, you can get this drug every 8 hours, right? If you're like little kids, like they have really good kidney function in most cases, we get that drug every 6 hours because they're clearing it so fast. You have to give the drug, basically they would be. If you didn't give it every 6 hours, you see that the level would continue to drop, and not get high enough in order to maintain that bacterial kill rate. So that's why you have to give it more frequently. If you have like an adult patient, they may only get it, say, every 12 hours. Or if you have like a patient with poor kidney function, they may get every 24, every 36, every 48 hours. So you may give the same dose to hit that same kind of peak level, but because they're clearing it so slowly, you may see that you'll start here and you'll wait because it's taking a long time for it to get down to that trough level, and we give another dose.
If you get outside of the therapeutic level for like one dose, like you miss a dose or late on a dose, how would it just have to give it for a longer period of time to make it effective again, or?
Not necessarily. Yeah. So again, because depending on the half-life of the drug, like you may see that if it's a very short half-life, you may be at steady state and you stop giving it for a day, you could be down to 0 and kind of starting all over. Most of the time, that's not necessarily the case. And so if you missed a dose, probably not a big deal. But that's why we tell people make sure they take a full course of antibiotics, because if they stop too early, even though they're feeling better, they can lead to things like antibiotic resistance. It can lead to recurrent infection, things like that. But usually one missed dose, not usually a problem. I'm trying to think of any other examples where that would be like a big issue. Not usually. Usually you have like some leeway with a lot of these drugs where you can give it within several hours of one another. If you miss a dose, generally not going to be such a big deal. It all depends. Any other questions? All right. So again, this explains why you take drugs the way you take drugs, right? So things like long half-life you don't have to take as often. So if you were to compare, for instance, NSAIDs, right? So you have ibuprofen. What's another popular over-the-counter NSAID? Aleve. Yeah. So naproxen is the generic name for that. What's the tagline for Aleve? All day strong, right? You only have to take it one time a day. That's one of the big things they market it on, because that's a longer half-life. I only have to take one dose a day in order to achieve therapeutic levels. Versus ibuprofen, how often do you have to take that? Every 4 to 6 hours or so, right? So it's more frequent, and that's because it's a shorter half-life. So again, it kind of goes back into like, okay, well, I can actually market off of this because it has an extended duration of action based on the half-life.
So that example though specifically, isn't naproxen considered to have a smaller threshold of when it would be toxic?
It depends on the patient. Most NSAIDs are going to have a pretty wide therapeutic index, and a lot of that stuff can depend on how long you're using the drug for, what other kind of comorbid conditions you have. There's a lot of factors that kind of go into it, for sure. So one other question? Nope. All right. Continuing on. So again, just kind of showing you, if we were looking at a single fixed dose versus a repeated fixed dose, again, just meaning we're giving the same dose consistently. You can see here, if we were to give just one-time dose here, you see this kind of peak come up, and then it would just kind of naturally just decay on its own, right, according to that first-order elimination. But by giving continued doses, you see the level continuing to rise, and then you'll hit that steady state around 4 to 5 half-lives or so. This is important for us from the pharmacy standpoint, because when we're doing therapeutic drug monitoring, sometimes we're measuring troughs of a drug, sometimes we're looking at peaks and troughs. But if you were to, say, measure a level at this point, and you say, okay, well, I think I'm at steady state, but you measure a level, say, after only this 3rd dose. If it's too early, you can prematurely think, well, the levels aren't high enough. I need to go ahead and up my dose. Then you change that dose, and all of a sudden their steady state level is even higher, and they actually achieve that, and that can lead to toxicity. So that's why it's really important that we are educating providers like, okay, well, if you're dosing vancomycin, don't check a level before the 4th dose. Because if you do, you're going to prematurely say, okay, well, I need to change my dose based on this level, even though it's falsely low, right? Because they haven't achieved steady state yet. So in a lot of cases when we're doing drug levels, it's important to allow it to achieve steady state first, and then you can measure levels and make some decisions on if I should give the drug less frequently or give a bigger dose or whatever happens to be. Okay, so it's important to achieve steady state because that's what the patient is going to be staying at for majority of time based on their dosing. Again, this picture kind of showing similarly what was on the last slide, looking at giving larger doses less frequently can achieve the same steady state levels giving smaller doses more frequently. Okay, so giving a drug every 24 hours at a larger dose can achieve the same steady state as giving a drug at a smaller dose every 12 hours. So, yeah.
So if you measure it after like 3 and not 4 type of thing, and you up the dose, you just end up miscalculating what their steady state would be. Like you think that it's higher, so that you give them that heavy dose.
Yeah, so a good example would be with vancomycin, right? So I'm shooting for a trough. You don't have to remember this number, but say I'm shooting for a trough of 15 to 20 micrograms per ml. Okay, and so say I were to check a trough, so right before the next dose, before the 2nd dose. So I haven't hit steady state yet, and it comes back and it's 10. So if it comes back at 10, I know that's too low. It's below my 15 to 20. What would be your instinct to do? Raise the dose. Okay, so then I raise the dose. Okay, and then I check it when it actually gets to steady state, and it comes back now at 24. So now I realize, okay, now that I'm actually at steady state, I've checked it after the next 4th dose, Now I see that I'm actually too high, and so then I can actually, and then I'm going to have to go back through and reduce that patient's dose in order to make sure they hit that 15 to 20. So if you do it prematurely, it can lead to toxicity, lead to unnecessary dose changes, where if I just waited till that the initial steady state, it would have been, say, 17 and a half. That would have been fine, right? So that's one of the big things we run into is that providers will prematurely change doses or change intervals before steady state, and that's not really a good number. It's not really an actionable number to do anything with.
Would it be safer to change the interval just to like catch it faster? Because like you give the next one in a shorter period of time, or you can give a higher dose.
Yeah, so it depends on the drug, and like, you know, if for some of them, if I get my levels too high, then that can lead to toxicity. So if I give a really big dose and I give it less frequently, that may lead to, you know, that ototoxicity I was talking about, or nephrotoxicity. Versus if I were to give smaller doses more frequently, I can maintain myself in that narrow window where I can achieve therapeutic effect, right, to my peaks and troughs. But I'm not seeing toxicity and I'm not getting subtherapeutic. So subtherapeutic is what we say when the levels drop below like an effective level, essentially.
Yep, so it's like if you're not sure if you need to increase the dose, you can like give the next dose fast.
Yeah, we don't usually monkey around with the interval if we can. Like, interval is usually decided based on, like, so you're looking at a patient and say, okay, you weigh this much, you have this good or poor of kidney function. You can usually kind of base your interval off of that, right? So I may look at a patient, you know, 70-year-old little old lady, poor kidney function, and say, you probably only need every 24-hour dosing of vancomycin, versus a small kid who I started on vancomycin, say, last weekend, got every 6 hours, right? Because I know their kidney function is far different between those two, and usually have like protocols for that sort of thing. What you find, though, is that the intervals that you give drugs are usually going to be based on, a lot of times, on convenience, right? So, for instance, like, you know, I'm not going to give a drug, sure, I could change my vancomycin trough by giving a drug every 7 hours, but, like, that's super inconvenient to even figure out when you'd give the drugs, right? There's usually pretty standard times. I either give a drug every 6 hours, every 8 hours, every 12 hours, every 24 hours, you know, those standard intervals. And again, if you think about it, like, you know, think about your nurse on the floor, right? How many patients do you think she's taking care of on a standard med-surg floor? Too many patients, right? So if she has to go and give a drug every 6 hours, that's a huge deal, right? Because I mean, she's always going back in that patient's room while she has all these other patient tasks kind of building up just to administer a drug, right? So it's one of those things where, like, you know, usually you try to take those kind of things into account. You try to factor in, like, you know, what's actually doable. You know, so maybe giving a drug every 12 hours is going to be more convenient for the nurse to give. It's more likely to actually occur on time, even though my windows, you know, my levels are going to be a little bit not perfect, essentially, you know.
So that you have like a longer interval time, if you're off of that interval time, is it more drastic than if it's a smaller interval time?
Yeah, you'd see more metabolism occurring during that period of time, so your troughs would go lower. Mm-hmm. Yep, that would occur. All right. So one of the things we can do for drugs that have a really long half-life is we can actually get them to steady state immediately. And we call this a loading dose. You guys ever heard this term before? Mm-hmm. All right, so loading dose is usually a lot bigger than what we would call your maintenance dose. So you start off with a loading dose, you basically get them up to steady state, and then you give the maintenance dose in afterwards in order to achieve or maintain that steady state, essentially. And so basically what we can look at for an example of this would be a drug like lidocaine. We're giving lidocaine. You mentioned that's a local anesthetic, you know, used topically a lot of cases, but sometimes you can use it for things like ventricular fibrillation. So for instance, I would give a 1 milligram per kilogram loading dose. This would have them basically, if you look at the loading dose, this is red line, and then your maintenance dose being this blue line, the levels start off very high, right, because they give you a big dose right up front, and then as that gets metabolized off, and I start a continuous infusion, say 20 to 50 mics per kilo per minute, that level is going to be gradually increasing, but I'm still achieving that same steady state level, right? So it just helps us to jumpstart the process and get to steady state immediately, rather than having to wait, you know, for several days or hours or whatever it happens to be. You know, patients in VFib, you probably want to get them to steady state pretty quick, right? You want to take care of that. Usually not compatible with life in a lot of cases. You guys ever, anyone, you don't have to raise your hand, but has anyone ever taken the Z-Pack, right? You take a Z-Pack, what's the first day's dose versus all the rest of the days? Yeah, it's higher, right? So it's like two pills versus one pill the rest of the time. And so that's based on a loading dose effect. You know, zithromycin has a fairly long half-life, but if I can give you a double dose on day one, that pops your level up higher, closer to steady state, and then I can give you the rest of the doses at a diminished amount, but it will achieve those levels higher for a longer period of time.
Is that the same concept so when you're taking ibuprofen or Tylenol, where like you can take 2 tablets on the first like dose and then add the twice as value one after that? I don't know if those are the correct
Some people will do that. A lot of that has to do more on the pain management side of things. Sometimes with like pain management, it's easier to give like a bigger dose to kind of get pain under control, and then you can kind of give like kind of maintenance doses. So like you may do like 2 pills first, and then you'd be like cycling ibuprofen, Tylenol like every 3 hours or something, and that helps to kind of get you gets the initial pain under control, and then kind of keeps it at a steady state pain level essentially.
Because I know there's some like providers that says like on your first you can take 2 if needed, and then
Right, so sometimes that's just to kind of get your levels popped up, kind of get you a little kick in the butt, and then maintains those levels a little bit higher.
so would that be an example of one?
Yeah, that's not usually like a common one I see super frequently, but that would be an example of that. Yep. Cool. So for instance, like the amiodarone, I mentioned that one having a half-life in measured in weeks. That's another one we would frequently give a loading dose of. So if patients in VFib or VTAC, give them a big loading dose of amiodarone, get their levels up high, and then I'd start a continuous drip afterwards to maintain that level at that steady state, at that therapeutic level. Because otherwise, if I were to, say we used 50 days as our half-life for amiodarone, and I have a patient who's in VTAC, and I give them just a standard maintenance dose of amiodarone, how long is it going to take them to get steady state? 4 to 5 half-lives, 50 days for a half-life, take a better part of a year. A patient's probably going to be dead by then, right? We don't want that. That's why we like loading doses, get them up to steady state a little bit quicker. Okay. I mentioned that maintenance dose is what we're going to give after the loading dose, and that helps us to achieve and maintain that steady state level within the body. And so the way we actually figure out what that maintenance dose is going to be is based on the steady state concentration that we desire, based on the dose, and then how the patient will clear it, and then the dosing interval as well. So we can actually rearrange that as well. So if you know what your steady state level you're shooting for is, you know how well the patient's clearing it, and you know what your dosing interval is, you can figure out the dose that I need to administer for that. So sometimes we'll actually calculate that out, and in a lot of cases it's already been done for you, right? So that's why they say, okay, well I can give you 500 milligrams of azithromycin on day 1, and then take 250 the rest of the time, and they've already figured out that's how you can maintain that steady state level. Okay. All right, I will give you guys, actually I'll do this example real quick. So this would be a drug called clopidogrel. It's an antiplatelet drug that you'll see used in patients who have had it's an MI, and they go to have a stent placed. This helps to prevent platelets from actually binding up to that stent, usually like the bare metal stent, to help keep those coronary vessels open. Platelets like to bind to that, so we use drugs to prevent that from occurring and from occluding the heart again. So essentially what you can do is use measuring levels. You can give a big loading dose. Sometimes it's given over several doses, but you give a big loading dose, and then once you get to that level, then start giving your maintenance doses. And so you can see how the steady state level is maintained there by the maintenance doses. Again, most of this is already figured out for you, but that's why you may see dosing strategies listed in your pharmacopoeia or wherever you're getting your information from. So looking at our variables, going back to talking about steady states and half-lives and all that good stuff. So again, given that our steady state level, which is the average steady state in most cases we're talking about, is going to be a factor of the dose, the clearance, and then the dosing interval. What are some reasons that we could achieve supratherapeutic concentrations? So meaning levels getting above our therapeutic index, putting the patient at risk for toxicity. What are some things that we could do to affect that or to cause that? Good, yeah, so too high a dose would be one, absolutely. So we give too big a dose, you can see toxicity, right? That level is going to increase. What are some other things we could do? So if the clearance goes down, that would also lead your steady state level to increase and put them at risk, right? So that's one thing we'll see with patients, especially like patients who are in septic shock, right? So septic shock, you get very hypotensive. You end up causing blood, perfusion to different organs ends up taking a hit in a lot of cases, right? So for instance, like, your body, like where does it want blood to primarily go to? If you had to choose 2 places you want blood to, probably the brain and the heart, right? So your kidneys, they're important. They can take a hit. They can take the back seat for a little bit with these kind of septic patients. So they end up having ischemic injury that can occur there, causing acute kidney injury, right? So that would cause an acute change in their clearance, leading that they might have been fine on a dose beforehand. Now that clearance has gone down, steady state level is going to go up, right? So those are things you have to monitor for, because that can lead to really big issues for patients if you're not being careful with them, right? And then how about with the dosing interval? What could we do with that to cause toxicity? Yeah, so we give it too short of an interval. So if we're giving the drug too frequently, right? So this can be a problem, especially for like patients who you may educate them. Hey, I want you to take this drug, like especially like a pain medication. I want you to take this every 6 hours, only as needed for pain. And they have really, really bad pain. Every 6 hours, just not cutting it. They're like, okay, I'm going to start taking this every 4 or every 3 hours. That's also going to be driving up their levels, can lead to toxicity. Okay. So again, sometimes patients, as you will hopefully not be too big a surprise for you, sometimes they don't listen to you, and they're going to do whatever they want anyway. So that can lead to some big issues as well.
So generally speaking, if you have a pain medication and it's not controlling your pain, is it better to increase the dose of frequency, or like you really just need to find a different medication?
It depends. For some drugs, you're going to find that, like things like NSAIDs and whatnot, like there's not a whole lot of benefit of really going above a certain dose. Like you only, like, there's going to be a plateau effect at a certain point where you don't really get any additional benefit. So in some cases, you can either give a bigger dose. Some cases, you can give the drug more frequently. Sometimes you will add on other drugs to act as adjuvants. Those are going to be things that kind of help other drugs work a little bit better. And then sometimes you will just switch drugs altogether, right? So my wife, she specialized in pain management. She did a second-year residency in that, right? She's a pharmacist as well. And so she works over ORMC, and so they have a pain service there where they'll evaluate these patients and, usually have a lot of pain issues. And so, the doc came back to her the next day after she had evaluated this patient, changed some things, like, wow, the patient's doing a lot better, because she had changed how frequently he was getting some of his medications, had added on another one that actually attacked pain through a different pathway, and had done a couple other things. So that's really her bag. She knows a lot more about it than I do. But by doing that, by using a couple different strategies, was able to get the patient's pain much better under control. Did not fix his constipation, unfortunately, so he was unfortunately being very objecting quite a bit to enemas and things like that, but you'll find constipation is a big problem with a lot of pain medications we'll talk about later on. So anyway, yeah, so all of the above you can do potentially. All right. So again, how can we combat these? So a lot of things we can do to prevent super therapeutic concentrations. One, usually trying to do either prospective dose adjustments. So if I know a patient has poor kidney function or poor clearance, I change the dose beforehand, right? If I know the patient has increased clearance, give a bigger dose, or I give the drug more frequently. So I can hopefully do that prospectively. Sometimes we have to do it kind of in a more kind of a reactionary kind of way, where we're measuring blood levels and adjusting it based on that. As much as you can do proactively, the better for the patient, right? So that way you don't have to do a bunch of dose adjustments. Things should be started on the standard dose, and you're good to go. Okay. So some of the things that can affect our levels as well, some of the kind of other factors you may want to take into account. So problems with absorption of medication, right? So compliance can be a big thing. What's compliance? Yeah, how well they're actually going to be sticking with your regimen that you prescribe for them, right? So this could be an issue where you have to consider the regimen and the patient, whether they're actually going to be taking the medication as they should, or they're kind of doing their own thing. Usually, easier is better. So if you can do things like 1 time a day. I'm a pharmacist, and I can barely take a multivitamin 1 time a day. So as you can imagine, some of these patients on like 15 different meds, it gets hard, right? So that's why I usually try to shoot for things given 1 time a day. We like to have things, combination products, so we can limit the number of pills you actually have to take. Like HIV is a huge thing where we've made huge advancements. If you ever look at like older documentaries, like back in the 80s, some of the drugs that patients had to be on, taking dozens and dozens of pills every, I guess not the 80s, maybe like early 90s-ish. They were taking dozens and dozens of pills a day, right? It was a huge problem for them. Versus nowadays, like some of the HIV regimens is like 1 pill a day, which was kind of awesome. So that can be a big thing to actually make sure your patients are taking the regimens that they should. Because obviously if they don't take it, they don't absorb anything. You can find problems with abnormal absorption in the bowel. This can usually be caused by either drug-drug interactions or drug-food interactions. A really good example of this is fluoroquinolones, which I mentioned, Levaquin being an example of that. It's an antibiotic used a lot, probably too frequently. But if you end up taking that with, say, a glass of milk, right? Because again, what do we tell our older female patients? Drink more milk, get your calcium, right? You don't want you to get osteoporosis. So if they take that along with the Levaquin, the calcium ions will actually bind up the drug and prevent you from absorbing it. Okay, so now all of a sudden they're taking the pills as they should, but they're not really getting into the system effectively. So that can be one thing. Sometimes drug-drug interactions, drugs can affect one another. So again, those are things we try to avoid to make sure the absorption actually occurs. So again, patient education is super important. Make sure you educate them on things like drugs they shouldn't take with grapefruit juice, or drugs they shouldn't, space out the drugs from when they take their milk, or whatever happens to be. So education is paramount there. And then clearance is another big factor. Looking at both their kidney function, liver function, heart function is a big factor for metabolism as well. Because again, if you're not pumping blood very effectively, if you're not getting blood circulated through the liver very well, the drug never makes it to the site of where it can be metabolized. So CHF, or congestive heart failure, is a big place where you see a lot of drug accumulation occur for some medications. This is where we need to make dose adjustments, and that's going to be very drug specific. So when you look up like a drug reference, like if you're looking at Micromedics or LexiComp or whatever you use, there'll be kind of a standard dosing section. There'll be one for like kidney dysfunction, how you should adjust it, and there should be one for liver dysfunction as well for most drugs. Some of them will be like, you know, I don't care what their liver function is, it doesn't matter, give the same dose. Some of it may be more dependent on just renal function. It can vary based on the drug. Okay. So again, what you end up seeing, some of the causes for these toxicities are due to identical receptors, but in different tissues or different pathways that I'm not really too interested in for their effects. So opioids causing constipation is a huge problem for a lot of patients. Never underestimate the value of a good poop for your patients, right? They can have huge effects on quality of life. My 1-year-old can tell you very specifically about that. She's not on opioids. We didn't start those yet. She just gets constipated. But basically, you know, so we give opioids because we want them to have their effects in the spinal column. We want them to have their effects up in the CNS. But we find that they affect the GI tract as well. Same opioid receptors. But this is where you get the constipation from. So it's kind of a toxicity through the same effector pathway, just in a different tissue. Sometimes this can be a good thing, right? So for instance, you guys ever heard of erythromycin? It's an antibiotic we'll sometimes use for infections, but we actually found that this can cause a different effect. It causes a lot of diarrhea in a lot of cases. This is due to its effect on this motilin receptor in the GI tract. It's actually when it stimulates that, it causes peristalsis at an increased rate, causing diarrhea. So sometimes we can use that for our benefit. If you have a patient with like gastroparesis or kind of impaired peristalsis, we can actually give this to them to help increase, you know, fix things like they have constipation or some issue like that. We can use erythromycin for that purpose. So like especially over at Nemours, we use erythromycin way more commonly for GI motility than we ever do for actual infections, right? So it's one of those things we may see uses for drugs kind of shift over time. Okay, so again, a lot of times toxicity can occur through supratherapeutic concentrations. This can be intentional or unintentional. Intentional, abuse. So can you imagine any drugs you might abuse? Opioids are a huge one, right? We're in the middle of an epidemic. Opioid. Anything else you can think of? Laxatives, yeah. So sometimes patients have eating disorders and they've used laxatives. You can use diuretics as well. So I had a friend who had a very short career in mixed martial arts. He lasted about 12 seconds before his shoulder dislocated, but he had access to diuretics and was able to get his weight down very much before their initial weigh-in. So he got very cranky when he was very dehydrated. So that was, you know, toxicity occurring from abuse. I don't advocate anyone actually do that. And then sometimes with attempted harm, a lot of overdoses occur not only on opioids but also other psych meds, you know, benzos, all kinds of different stuff. So we see a lot of suicide attempts, especially through the ER. So you know that's really where I got a lot of my training at, was in toxicology from that standpoint. Unintentional, you can have children accidentally getting into things, obviously, because they are very curious and they like to get into stuff and put stuff in their mouth. And they could also have problems where, you know, unintentionally levels will build up if the patient does not have good clearance due to either their age as they get older or due to renal function, things like that. So just remember, everything can be a poison, just need the right dose. Oxygen can be poisonous, water can be poisonous, anything can be, if you have enough of it. Okay. Keep in mind, most substances do not have antidotes. My #1 recommendation for patients who have overdosed on substances is going to be supportive care. How useful is that? Not very. But because we don't have a lot of antidotes for stuff. So tincture of time is going to be the best cure for most things. Give the time for the body to metabolize drugs, to get rid of them on their own. Sometimes this can take a very long time if you have a drug with a long half-life. Sometimes it can take a short time. Just depends on kind of what they did. But again, good supportive care is going to be the big thing we'll do for most of these patients. That just means, you know, if they're hypotensive, give them fluids, give them vasopressors. If they're hypertensive, give them drugs to correct that, right? So not a whole lot you can do specifically. So it's really important to try to avoid toxicity whenever we can. Okay. So any questions on those kinetics? Move on to the next section. But we're going to continue on. We're going to talk about bioavailability and bioequivalence. We'll talk a little bit more about adverse reactions and define some of the different types of adverse reactions that you can see here, and then we'll talk about bioavailability and bioequivalence. So adverse reactions are going to be anything that can be an appreciably harmful or unpleasant reaction due to a medication. Usually can result from an intervention related to the use of a medicinal product, right? So giving you a drug for something, get some sort of untoward event, that can be considered an adverse reaction. And so usually these will also predict hazard from future administrations. In most cases, if a patient had a bad reaction to a drug the first time you give it, they'll probably have the same reaction the second time you give it in a lot of cases. This means that we can either try to prevent it somehow or by giving a specific treatment. So for instance, if you know a patient when I give a certain drug that they're going to have an allergic reaction, I know they're going to have a lot of histamine release, sometimes we have to treat them with drugs beforehand like steroids, antihistamines, things like that to prevent that reaction, because that's a life-saving treatment, right? We have to give them that drug, so we can give them something beforehand to prevent that. Sometimes it will lead to alterations in the dose that we give, maybe give them more or less drug. And then also withdrawal of products. We can see withdrawal being a common reason for things like issues with opioids or alcohol, things like that, where we can see withdrawal phenomenon that can occur. So it'll be considered like an adverse reaction. So the 6 categories we're going to talk about, and again, you'll hear me probably mention side effect and adverse effect, and probably very kind of similar circumstances, probably interchange those terms. But these are the main 6 categories you'll see with adverse reactions. So there could be dose related. It's kind of an augmented effect. We'll go into these in more detail, but the first one's dose related. You can have kind of non-dose related, kind of these bizarre reactions that are much more kind of idiosyncratic. You can have dose related and time related, or issues with chronic administration of drugs. Some of these are going to be time-related or delayed effects, where you may give a patient a drug for a really long time, have no problems, and all of a sudden they develop an issue later on. Withdrawal, and then also failure of therapy. So you can kind of use this A, B, C, D, E, F mnemonic in order to try to remember these different types and kind of how they are going to be affecting the patient. All right, so the first one we'll look at is going to be dose-related or augmented effect. These are very common, and they're going to be related back to the pharmacologic action of the drug. So if I know that if I give a patient a beta blocker that blocks beta receptors, I know pretty well that's going to be causing the same effect regardless of which patient I give it to, right? And so it's going to be related to the dose. Usually it's going to be predictable. So if I know if I give too much of this drug to this patient, they're going to have an issue. If I do the same thing 2 days later, the same effect should occur. And usually it's going to be pretty low mortality for the most part. So usually not a huge issue. Usually you can kind of see it happens the first time and usually kind of correct for that. But you do include a lot of the normal kind of side effects you consider with a drug. So a good example of this would be sedation with antihistamines, right? So diphenhydramine or Benadryl. You take it, say you were taking it at 8 o'clock this morning, you guys should probably be asleep right now, right? Maybe some of you already did. Of course, you can use these for therapeutic effects as well. So if I know if I'm having an allergic reaction and I'm about to head to bed, that's probably okay if I'm a little extra sleepy during that time frame. Hypotension with a calcium channel blocker. So these are drugs that are commonly used as antihypertensives. If I give you a little bit, that may get your blood pressure under control. If I give you too much more than that, you can see hypotension develop. So again, very predictable, all related back to the mechanism of action of the drug. You have non-dose related or kind of these bizarre reactions that are uncommon for the most part and typically are not related to the pharmacologic action, right? So if you had a weird reaction that occurred after I gave a beta blocker, but it really had nothing to do, excuse me, with the actual beta receptors, this would be kind of considered one of these non-dose related effects. Pretty unpredictable. It's hard to screen patients to determine who's going to be at risk for this reaction. A lot of this comes down to pharmacogenomics and things we don't really have the setup to test patients for. And you typically see higher mortality associated with these. So a good example, oh yes sir.
Would fluoroquinolone affect following this?
Yes, because you don't really, yeah, so one of the big black box warnings you would see like on a fluoroquinolone like Levaquin is risk of tendinitis and also tendon rupture, especially the Achilles tendon. That's one of the things we can't predict really who is at risk for that. You know, you may have certain subset of patients where, okay, children, I don't want to use this drug in because I'm worried about them in particular. They seem to have higher propensity for that to occur. But yeah, it's hard to predict who will have issues with it. Yeah, absolutely.
Hey, this may happen, we don't know.
Yeah, so it can be either, right? So sometimes, like especially for like codeine, I mentioned before, I mentioned patients with that 2D6 polymorphism, they're at risk for having respiratory depression and death, right? So that's for a specific subset of patients that black box warning is for. Sometimes it's just like, hey, this weird reaction may occur and they may die. We don't know who's going to be at risk for it, right? So it kind of runs the gamut of different things. And sometimes we'll talk about REMS programs, but basically sometimes if there's a really bad side effect that is bad enough to warrant kind of extra precautions, the government will put in place usually like registry programs and things like that to help prevent an event from occurring. So a good example, you guys ever familiar with the drug Accutane? Used for, do you guys know what you use it for? Yep, use it for acne. That's one of those things where the prescriber has to be registered with the iPledge system, which is the REMS program they put in place. The pharmacist has to be registered with the pharmacy. The patient has to be registered with it, and they also have to take a bunch of pregnancy tests. Do you guys know why? Birth defects, right? So they want to make sure, because they know that if a patient is on Accutane and they get pregnant, they're going to have birth defects. That's one of those things where it's a very much a known quantity. They make sure that the patient who needs it is not going to be at risk for getting pregnant, right? So it's a lot of education, a lot of pregnancy tests they have to do, and so it's one of those things they try to do to prevent those any events from occurring.
What about men that are on Accutane?
They actually recommend that men use protection as well when they're on it, because there can be some transfer to females. I don't know if clinically it's ever popped up where that was I don't know if a birth defect has ever been ascribed to a man being on it during intercourse. I can't say for sure, but they do recommend backup methods for that. Yep. So anywho, typically higher mortality associated with this, or just more morbidity associated with it, right? So like teratogenic effects could certainly be something you may consider. So allergic reaction to penicillins, right? So I could probably give most of you guys penicillins here in this room. Most of you probably have no problems, right? Small chance that some of you may have an allergic reaction. There'd be no way for me to predict that unless you had a previous allergic reaction and it's on your chart, right? So that's why making sure we have proper documentation of things like allergies is super important. Also, you have a lot of false positives for things like allergies. I'll probably complain about this a lot when we talk about antibiotics. But is diarrhea an allergy? No. Is vomiting an allergy? No. But a lot of people will just say, I have an allergy to penicillin. What happened? I had diarrhea. Still, that gets put in the chart, and then it stays there forever, and then you can't ever give them penicillins, and you lost a really good class of drugs. So it's one of those things where, like, if you know something's not really an allergy, take it off their chart, please. Like, that just makes life easier for everyone. So.
I have a question though. Like, what would you categorize it as? Because my sister can't take like a certain type of multivitamin. She vomits every time. So like, what is that?
That's an adverse reaction. Like, it's just one of those. Right, exactly. So you can avoid that drug, right? But you still don't want to say it's an allergy. Yeah. Okay. Right. Because you don't want to say, like, she can't ever take a multivitamin ever again.
No, yeah.
Right. Yep.
If there's like an alternative method, or it's just because it's not under allergic reactions classification.
Yeah, because as soon as you put something under an allergic reaction, like, even if you, like, a lot of people won't even look at the actual reaction that occurred. If it's documented at all, it just says allergies, penicillin, and that means I cannot use amoxicillin, I can't use dicloxacillin, I can't use piperacillin, any of the penicillins. Now all of a sudden I can't use any of those because, and then a lot of cases like, oh, my mom told me I was allergic to it. What happened? I don't know. It's a baby. Yeah. Not super useful, right? So this is one of those cases where good history taking can be very important. Sometimes, like if I have kind of one of those kind of I have a feeling it's a bogus reaction, I'll be like, well, just give them a dose here in the ER. That way, if they anaphylaxis, we can at least treat it here. That's literally what we do. I'm like, okay, let's just try this out just to make sure they're okay, and then sure enough they're fine for the most part. I've never had anyone actually have a really bad reaction, so usually have to have a pretty good gestalt that it's kind of bogus. So yeah. You're going to learn lots of stuff from me. Anyway, so another example would be something like malignant hyperthermia after receiving general anesthetic. So this is a very rare reaction that occurs. Essentially, also a paralytic called succinylcholine will sometimes given when we're intubating patients. Basically, patients who have an altered ryanodine receptor. We'll talk about that ryanodine receptor when we get to the second section of physiology. But basically, they end up having way too much calcium release from the sarcoplasmic reticulum. All their muscles start to get very tight and contracted, and they start to produce a lot of acids and a lot of heat, and they get very, very sick and can die very quickly. Okay, so it's one of those things where that you always ask before someone undergoes anesthesia: has you or your family member ever had a bad reaction to anesthesia? Okay, if that's the case, because that is a genetic link, if your parents had it, you're more likely to have that altered receptor as well, and that's one of those things we can actually try to screen for prior to giving these drugs to make sure they're not going to have a bad reaction to that. Okay, it's not something I can predict in any individual patient, but it's one of those things you always want to be kind of keep on the back of your mind. Okay, looking at kind of chronic toxicities that can occur. These are relatively uncommon, but it's going to be related to kind of cumulative dose over a long period of time. So one of the good examples of this would be adrenal suppression with corticosteroids. So we've already talked about this a lot in physio. So now the nice thing about me teaching physio is I know exactly what you guys have already covered. So blank faces are not allowed when I say, like, remember this? And you go, yes, you do. So again, when you have exogenous corticosteroids being administered to a patient, what does that do to the adrenal glands? downregulate, say, hey, we don't really need this because that negative feedback loop is being affected. So your ACTH should be low, your CRH should be low because I'm giving these exogenous steroids. So for instance, that can be fine and dandy if they're at a kind of a good baseline, but all of a sudden if I take away the steroids, what happens? The adrenal glands are going to start to atrophy a little bit. It takes time for them to really kind of ramp up production again of cortisol in order to maintain normal glucose homeostasis, normal blood pressure, things like that. So that's why we would build in tapers into those doses where you give a smaller doses over a period of time and make sure their adrenal gland kind of kicks back up production.
Would the glands not already be atrophy if they were on corticosteroids for an extended period of time?
They would start to atrophy, yeah, when you're on it for that long period of time. Yep. Yeah, so that process would start pretty soon after they started the glucocorticoids. Because again, once that negative feedback loop gets hit, or signaled, it says, okay, we don't need to produce cortisol anymore, and then it starts to downregulate.
Would certain antidepressants go into this because you don't produce your own dopamine anymore? I heard that's a thing.
No, most of the antidepressants are mostly working through serotonin. Certainly you can have withdrawal effects. We'll talk about that in a second. So that's a very common thing you see where we'll still taper down patients on antidepressants, but it's not related necessarily to this so much. That's more kind of a specific withdrawal effect. Another good example of where these can pop up is going to be patients who have altering renal function over a period of time. So for instance, really old drug used for asthma or COPD called theophylline. You guys ever heard of that one? Mm-hmm. Used very rarely nowadays, but the kind of the classic thing I always think about are these little old ladies who get put on theophylline probably 10 years ago. They get put into a nursing home, and no one ever reassesses their renal function or in their dose. So over time, that 10 years, their renal function is getting worse. Theophylline levels going up, and then they have toxicity. They usually present with seizures and all kinds of bad stuff. So it's one of those things where you have to kind of monitor changes in function over time to make sure that chronically these levels don't build up. So that's one of the big things we want to watch for, especially in your kind of at-risk patients. Okay, so time-related or delayed reactions, again, are pretty uncommon, generally not related to dose necessarily, and will only occur or become apparent sometime after the drug use. So it's not really immediately, could happen sometime far after. So teratogenesis is probably a good example of this. So for instance, if you were to have Accutane, right? So I could be taking Accutane for my acne. It could be improving my acne, everything's great, but there could be a lag time between when you get pregnant to when you find out, right? Damage has already been done at that point because organogenesis happens very early on during pregnancy, and so you may not notice until the kid's born that, hey, they had exposure and now they have all kinds of developmental issues, right? Same thing about valproic acid is a drug we use for patients with bipolar disorder or seizures, and so this can cause neural tube defects. This is one of those big things we want to watch for. Make sure patients are not pregnant before taking this and things like that. Another good one is tardive dyskinesias. You can see with antipsychotics. This would be a case where you're kind of altering dopamine physiology over a long period of time, and so you can actually end up kind of seeing changes to the receptors that actually get really super sensitive to dopamine and cause all kinds of side effects. So just be aware that this is a thing where you can take the drug for a long period of time. It's not really related to the dose, but these effects occur kind of later on and don't really become apparent for a while. Okay. Do you know when a joke becomes a dad joke? And the punchline becomes apparent. So the withdrawal effects, I know you always hear that second wave of like, oh, okay. All right, so withdrawal effects, these are things that occur soon after withdrawal of the drug. This depends on the half-life, right? So drugs with a long half-life, do you think withdrawal would happen soon or far after you stop the drug? Far after, right? Because again, the drug levels stay high for a long period of time, so they would end up kind of gradually going down, which can be useful, right? Sometimes we like to use drugs with long half-lives when we're trying to wean a patient off of something, or if they're prone to stopping therapy kind of erratically, that can be useful to use a long-acting drug. So, for instance, patients with depression, right? If they're taking something like a selective serotonin reuptake inhibitor like Lexapro or Prozac or something like that. They may be prone to just stop taking their meds. And so if they do that, they can have these withdrawal effects where they get really kind of anxious and they get they sweat and they can't really sleep very well and they get GI upset. But if I use a long-acting drug, if they were to come off of it, then the levels kind of just gradually go down on their own. It limits that withdrawal effect, right? Opioid withdrawal is also a really, really big problem we run into, especially with patients. They run out of their normal doses. They go into withdrawal. You have really bad diarrhea, and they get diaphoretic and anxious, and they're really angry in a lot of cases. So that could be one thing you see. Withdrawal effect can also occur with some antihypertensives. So I mentioned that example with upregulation of receptors in response to like beta blockers, right? So you can actually see patients who are on beta blockers for a long period of time. Those beta receptors, they upregulate or downregulate. So you put a beta antagonist on the beta receptors on the heart. Upregulate, right? Because again, when you're inhibiting those effects, when you're blocking those receptors, the heart's like, well, I need more receptors to get hit then. So it upregulates those receptors. And then all of a sudden, if I pull away the beta blocker effect, now all those receptors can now be affected by things like epinephrine, and you can actually see myocardial ischemia due to increased cardiac output, right? So it can be a thing where you can actually see rebound MI occur secondary to drug withdrawal. Not common, but again, it's one of those things where you can at least predict it and try to taper patients off their doses over a longer period of time to make sure they don't have these withdrawal phenomenon. So we do this frequently for ICU patients, especially those that have been intubated for a long period of time. Usually you stay intubated, we sedate you with benzodiazepines like Versed or sometimes like Ativan, and then we'll keep you sedated with opioids as well. So usually like fentanyl and like Versed are the two drugs that usually keep you sedated on. When you are ready to be extubated, if we were to take you off both of those drugs, you can have those withdrawal phenomena. So what we'll actually do are these tapers where we can switch you over to some other longer-acting drugs, like methadone's a really common one we use for some of those kids, and you can actually taper their doses down over, say, a few weeks or so, right? And if they start to see withdrawal effects, then you kind of up the dose a little bit to try to chill them out, and then you can start to taper again, okay? So again, you don't need to know specifically the individual drug examples for testing purposes, but if I say, hey, a patient was taking this drug for 3 years, never had any problems with it, and all of a sudden developed this reaction, what type of adverse reaction would that be? Those are the type of questions I try to get to get more of the concepts than the individual drugs. Okay. So you can have an unexpected failure of therapy. So this can be somewhat common. Usually it's going to be dose related, or it could be caused by things like drug interactions. So we see this a lot with, for example, like the fluoroquinolones binding up with calcium, prevent absorption. Drug levels are not going to be able to get to high enough to kill bacteria. Sometimes you can see this with oral contraceptives and enzyme inducers. So if I were one of the places that estrogens and progestin gets metabolized is within the liver, if I have enzyme inducers, or especially like some CYP enzymes, more enzymes around, what does that do to metabolism of the oral contraceptives? Increase or decrease? Should increase because I have more enzymes available to metabolize it, right? So my levels of oral contraceptives drop faster than what I would expect, and then what does that put you at risk for? Pregnancy. Not usually an adverse effect you'd like to have if you're not ready for that sort of thing. So that's one of the things you worry about because a lot of seizure patients, they're on drugs that induce enzymes. And so that's one of those things where we have to either use backup forms of contraception or use something like an intrauterine device or like a copper-based intrauterine device to prevent implantation, things like that. So there are alternatives you may have to use based on your other patient's meds or disease states, things like that. Okay. So adverse reaction versus side effect, you'll probably hear me kind of mix up the terms. They get used pretty frequently in place with one another. But side effect usually going to be one of those things that's going to be a little bit more minor, usually kind of an undesirable effect, but it's usually not going to be a life-altering kind of thing, right? It could either lead to things like changing the dose you're using or just changing meds altogether. Just depends. But side effects can be a really good thing in some cases. So you guys familiar with the drug Latisse? Yeah. What do you use Latisse for? Yeah, makes your eyelashes longer and fuller, and you look generally more beautiful. But when it really started out as a drug for glaucoma. So you can use prostaglandins. I mentioned prostaglandins in physiology are useful for dropping intraocular pressure. Okay, but one of the side effects that people noticed was that, hey man, your eyelashes are looking really good lately. Oh, my glaucoma. So they basically were able to market it under a new brand name and then sell it for this purpose, right? For now, so it's more of kind of a visual aesthetic kind of thing versus just using it for glaucoma. One of the undesirable things you may see though is that it can actually turn your iris brown. So you can actually see some browning that occurs over a long period of time. If you already have brown eyes, not a big deal, right? But if you have nice pretty blue eyes, you may not want that to occur. So it could be one of those kind of things where you educate your patients, say, hey, this is a potential. If you do not want this irreversible browning to occur, then maybe you shouldn't risk it. So it's one of those things where you cannot always predict who's going to have the side effects in all cases.
Had that happen, let's say blue eyes and then they turn brown, could you pass that on to your child?
No, it's not necessarily the genes are not being changed necessarily. It's more of just the melanin production that occurs secondary to the prostaglandins and all that. I thought I had a picture of that. When we hit glaucoma meds and get to Farm 1, you'll see more pictures. But you can kind of look, if you like Google Latisse or bimatoprost and iris brown, like you'll find some pictures of that. So that's a side effect. Generally, if my eyes turn brown, probably not going to change my life for the most part, unless I was like an eye model or something. I'm great. I'm just kidding. But looking at like adverse reactions tend to be a little bit more on the severe end of the spectrum. So you guys ever heard of the drug Bactrim?
Yeah.
What do you use it for?
Bacterial UTI.
Yeah, usually UTI is a very common one. So Bactrim or sulfamethoxazole and trimethoprim, it's actually a combination drug. One of the things you really want to worry about are going to be skin reactions. So a side effect could just be a little bit of rash or urticaria, especially that photosensitivity where they're a little bit more sensitive to sunlight. That can be a side effect, right? So you can either switch over to a different drug. It's usually not going to be too problematic. On the other hand, you can have what we call Stevens-Johnson syndrome. So if you ever had a patient who started to have like skin start sloughing off or new blistering, anything like that, that's a big thing. Like that could kill you. You need to get into the hospital immediately for evaluation, right? And that would preclude them from ever getting that drug ever again, right? Because you wouldn't want to have a reaction kind of represent itself. So just be aware there's kind of a spectrum there. You may hear adverse effects and side effects being used kind of interchangeably, but typically when we're talking about like kind of big deal things, morbidity, mortality, we're thinking more adverse reactions. Other interactions or other kind of delineations here. So like Viagra or sildenafil, right? We said we use that for erectile dysfunction. The side effect causing some upset stomach. A lot of it goes back to the fact that it's affecting phosphodiesterase. So phosphodiesterase is important for metabolizing cyclic GMP. You guys remember that? Right? You guys should probably have studied that sometime recently. That can actually cause some smooth muscle relaxation, cause some loosening of that lower esophageal sphincter, so you can have some reflux and upset stomach. But also you can have sudden loss of vision. Probably not good, right? So if I give a phosphodiesterase inhibitor, and now all of a sudden I have a lot more cyclic GMP around, what does that do to my vision? What does that kind of stimulate?
Opening up in sodium.
Yeah, they'll have open sodium channels, right? You're not going to have hyperpolarization of those cells, and then what happens? It's going to be like you're in a low light condition, right? So you can actually have sudden loss of vision in some cases, which you probably want to stop taking the medication at that point, right? And so you can actually find that certain drugs will have so within that class, some of them will have more affinity for that phosphodiesterase, some of them will have affinity for other types of isoenzymes. So you can sometimes get around these kind of adverse reactions if they have a history of that. Another one is going to be with ACE inhibitors, lisinopril being one of the more common ones you'll see being used. An adverse reaction would be angioedema, right? So this is one of those things where we cannot predict who's going to experience this. Essentially, they get a lot of airway swelling, their tongue gets super big. What do you think the biggest risk for this patient is at this point? Airway closure, yeah. So this is one of those things where we have to get them intubated post-haste, otherwise they could lose that airway. We actually sometimes have to, usually when you're trying to intubate a patient, use like a laryngoscope to kind of put it down their throat, kind of open things up so you can pass an intratracheal tube down through the vocal cords. In these cases, I've had patients like this. After a ACE inhibitor-induced angioedema, we actually had to use a fiber optic scope to go nasally. Put that down through the vocal cords and then use a smaller tube and actually snake that through because, again, you're not going to be able to get any kind of visualization when you have a patient like that who's that swollen up. So you actually have to go nasally and intubate a patient that way. So, again, it's going to be pretty severe, pretty life-threatening in some cases. Yes, ma'am. That's the thing you're trying to avoid. Usually, like, you bust out the trach kit and you try to ward away the bad mojo by having that out. Like, you pull it out just in case, but you never want to use it. So, yeah, it's one of those scary situations. So you try to intubate early to prevent that from actually occurring. Yeah. But a side effect, so I don't know if anyone's ever taken ACE inhibitors or has a family member who's taken it. Cough can be one of that's kind of dry, non-productive cough can be a big adverse effect or a side effect for a lot of patients. It's due to this buildup of bradykinin. It's kind of a secondary effect of the drug's mechanism. This can be very problematic for a lot of patients. Like my cousin, whenever he took an ACE inhibitor, he always had such a bad cough. He's like, I just can't live with this, and had to switch over to a different class of drugs. So again, some of it you can fix by changing the dose. Sometimes you have to switch drugs altogether. Okay, so when looking at trying to make sure drug safety is a huge thing. You'll find that there's going to be a lot of things put into place to try to ensure drug safety in patients, especially if like you work in a hospital somewhere. And you may say, this is really dumb. Why do I have to do this to prevent this really kind of obvious thing from occurring? And it's because someone's probably done it, right? So healthcare providers are not immune to human mistakes, and so it's really important that we do things to make sure that we have the 5 rights. So we talk about the right drug, right patient, right dose, the right route. We had a patient who, this is over, my wife actually told me about this, one of her, the nurses she was working with, this patient was getting lorazepam, which is a benzodiazepine. It comes in an oral form or it comes in an IV form. And so this nurse was getting these oral syringes of a liquid form of lorazepam, which should be just administered orally, and that's it. This nurse was not aware of that, and so she said, well, this is a funny looking syringe. Usually things are meant to not interconnect, like oral things should not go to IV lines, right? But she's like, this is weird. I'm going to go draw this up out of the syringe, put it into a regular syringe, and then administer that IV. So now you got a bunch of stuff going into the veins that really aren't meant for the veins, right? It's a lot of like, you have like coloring and preservatives, all kinds of other crap that's in there. Patient did fine, but it's one of those things where you got to really make sure you have the right route for this kind of stuff, okay? The right timing is important as well, because if we're giving things too late or too early, that can also lead to some problems with our levels, right? So getting the right drug can be harder than you think in a lot of cases. You have to be cognizant of different drug brand names. You have to be cognizant of different forms of drugs. For instance, you may have a drug that's in the XR formulation or the SR formulation or the ES formulation. They all can mean different things about the release characteristics, how often you give a drug. A really good example of this is a drug called Wellbutrin. You guys ever heard of that one? You use it for depression in a lot of cases. And so that Wellbutrin comes as an SR formulation, which is every 12 hours, or an XL formulation, which you give every 24 hours. On the intake, if the nurse gets down the wrong formulation of the drug, or the patient doesn't really delineate that, you can be prescribing the wrong one. And then all of a sudden they're getting either too high of a dose or too low of a dose. You can see issues with either one there. So be aware of that. If a patient says, oh, I take Tylenol. Well, what does Tylenol really mean? Like, Tylenol uses their brand name on all kinds of different products. Does that product just have acetaminophen in it, or did it have Benadryl in it too? Did it have other cough and cold products? Like, you need to be specific about a lot of these to make sure you're getting the right information. We see this pretty frequently here in Orlando because we get a lot of international travelers. So I'll have patients who will come in with either drug vials and things like that of medications in a completely different language. Portuguese is a big one. Have a lot of Brazilian travelers, Spanish, all kinds of different things. And you have to go to your Google Translate and figure out specifically what it says, so I know how often or how much a patient should be getting this. Common names you'll see that may be mixed up. Albuterol. What do we use albuterol for? Use it for asthma. That's actually called salbutamol over in the UK. So if you have a patient on salbutamol, you have to be able to know that, okay, that's albuterol. Or paracetamol is the UK version of acetaminophen, right? So just be aware there's different brand names out there, different names for things. Be aware that, sometimes you have to do a little bit of homework and actually find out, or go to your Google Translate and figure out what it is. The right patient. You might find it actually very difficult to give the right patient the drug you're actually looking for, right? So what do you do prior to surgery to make sure you don't, cut off the wrong limb? You should write, you should probably write on it. ID, yes, we do a timeout. So that'll be something you'll encounter, where basically everyone times out and say, okay, stop what you're doing. Let's announce what specifically we're doing here, the procedure, who the proceduralist is, who's in the room. You have to do all of that because, again, that helps to prevent doing things to the wrong patient or the wrong, the wrong limb or something like that. Same kind of thing needs to happen with medications as well, because you give the medication to the wrong patient, can be problematic. We run into this very frequently with siblings. So imagine if we had 2 twins that were born in, at an outside hospital, gets transferred to our NICU. Now we got baby A and baby B. Okay, well, does this drug go to baby A or baby B? Like, yeah, it says it on the label, but maybe you get that wrong and mix up which baby's which, right? My sister couldn't tell her 2 twins apart for at least the first 3 months of life. They look very similar, even though they weren't identical. So, and also, like, be careful, like, when you're doing things like, oh, the patient over in room 3. Well, that patient could have switched out and been someone else, several times over, depending on the time frame you're talking about. Patients move around constantly, so that can be, always make sure you're using the correct names. We do a lot of barcode scanning in our hospitals now, so you're seeing more and more places move over to that, where you have to barcode scan everything, medications, wristband on the patient, computers, all kinds of stuff to make sure that, yes, you had the right person to administer this drug to. So that can be a very useful thing to prevent errors. You want to make sure you have the correct dose based on things like their age, their gender, renal, hepatic function. All of that is very, very important to check before you hit the prescribe button on a lot of those. And then the home medication reconciliation is extremely important for this as well. And make sure you're getting the correct information from the patient, that they have been thorough in including all the information that you need to get a full med list, or they could be lying to you about some of their med list. So one of the things you'll learn when you're taking history, if you ask a patient how much they smoke, you should probably double the amount, they say they drink, and you should probably half their methadone dose, whatever they tell you. So an example of this. Fortunately, my wife was not actually involved, but she had heard about it. But over at ORMC, a patient came in who's on methadone. I said, oh yeah, I take like 60 milligrams every 6 hours, which is a crazy high dose, but not unheard of. No one bothered to verify this with like the methadone clinic or any pharmacies. Patient gets prescribed that on the inside. The prescriber just went ahead and hit reorder, and so patient ended up getting that. Found him not breathing the next morning, right? Go and give him Narcan to wake him up, and doing fine. But yeah, so once they verified it, he was on half that dose maybe. So it's one of those things where you have to be really careful, make sure they're not trying to game the system at all to get more drug than they should. You know how we can tell if a patient is lying to us? Their lips are moving. Yeah. That's more important for like a tox standpoint. Usually, if you're just having like a well check or something like that, you probably should be truthful. But we lie to our pediatrician, like. Patient sleeping in her crib, like, yeah, most of the time, sometimes no. Yeah, we're bad parents. So again, ensuring the right route of medication. So this is a lot of things are put in place to prevent this. So vincristine is a common chemotherapeutic drug, and lethal if given intrathecally, right? So intrathecally, you administer through an epidural. And so this is one of the things where, like, oftentimes they're getting medications. We might give another drug called methotrexate intrathecally. At the same time, they're getting vincristine. If those ever get mixed up, you can kill the patient, right? So this is one of the things we do a lot of methods to prevent that from being given the wrong route. Sometimes you can give drugs in non-traditional routes. So, for instance, the laxative Docusate. Sometimes we'll actually put that in the ear. Do you guys know why? It's a stool softener, but it can also help to, so it actually helps with cerumen buildup. So if you have a patient who's got impacted cerumen, sometimes we'll put a little Docusate in the ear, kind of help to loosen it up, and you can flush it out. Right, so it's kind of I'd never seen that before until I was working in a PTR, and I was like, why the heck do you order this via the ear? And that makes more sense once you know that. Some cases we'll give oral products via the intravenous. This is very rare that we would do this, but we used to do this kind of more decades ago. But a drug called N-acetylcysteine or Mucomyst is the antidote for Tylenol overdose. And we used to only have an inhalational product or an oral product. It was sterile, so we can give it IV, but it's an uncommon thing that we do nowadays. Some drugs can only be given via certain routes, otherwise they cause toxicity. So for instance, phenytoin is a drug we use for seizures. If you give it intramuscularly, it causes tissue necrosis. I showed a picture of that. We were doing the different dosage routes, and you saw that purple glove syndrome. That was from extravasation of phenytoin into the surrounding tissues. That's why we can't give that drug intramuscularly. Drugs like vitamin K or phytonadione, if given intramuscularly, you can see a hematoma form. So that's why, in a lot of cases when you're dealing with like electronic medical record systems, they hardwire a lot of that stuff into it. So that way, I can never order phenytoin intramuscularly. The option is just not there, right? You can only do it IV. For vitamin K, it would only let me do, intramuscular or, sub-Q for that one or oral, something like that. As idiot-proof as possible, but again, there's a lot of idiots out there, so we can still cause errors. So again, timing certain medications can be really important. If patients are taking too much Tylenol too frequently, hepatotoxicity can happen there. Pain medications, they can end up seeing increased sedation or respiratory depression potentially. Also, like things like emergency contraception failures. If you are not taking emergency, so this is like Plan B, right? So if you have unprotected intercourse and patients are worried about becoming pregnant, they have like a 72-hour window to take their Plan B. If they don't, then there's increased risk for pregnancy. So timing can be really important in that. If they're too scared or they're too worried about getting emergency contraception, that can be a barrier to them getting it on time. And then antibiotics given too infrequently may lead to worsen infection or resistance. So for instance, some of your patients may be a little bit more frugally minded, and they're like, well, they told me to take this penicillin every 8 hours. I'm just going to do it one time a day, and that way it'll last me, and I can save it for next time. Probably not a good idea, right? So some of them might be taking things inappropriately. We call this kind of mindful non-compliance, where they tell you they're doing something they're supposed to be doing, and they're really doing something different, right, on purpose. Okay. I think we're going to go ahead and cut it there. We'll come back and continue our talk about bioavailability. Do you guys have any questions before I let you go? No? You guys are all drugged out? Okay. All right, I'll see you next time.